Okay, so first we're gonna go through thyroid, and then we'll go through gallbladder after. Initially, I just kind of want to go over the general endocrine system, so you guys get kind of an idea about it. Let me hide this right here. Okay, that's getting in the way. Okay, so in general, your hypothalamus is going to be one of your, in general, is going to do a lot of things, control your vital signs, go control a lot of like your thermal regulation, electrolyte balance, pain, does a lot of stuff. But really, for this, we just want to know that it releases thyrotropin releasing hormone, or TRH, which stimulates the pituitary gland to release thyroid stimulating hormone, TSH, which is known as TSH, and it's also known as thyrotropin. So that's why you can see that makes sense here. So hypothalamus stimulates the pituitary gland to release TSH. So pituitary gland, specifically the anterior pituitary gland, is going to be releasing your TSH. Um, of the thyroid release T3, sorry, T4. Okay. Is that clear to everyone? Kind of how that goes? Cool. And let's talk about the negative feedback. Anyone explain what the negative feedback refers to? Not quite, um, not quite, but it's very similar. Essentially, it almost like self-regulates. It's like a self-regulation kind of thing. So I would refer to this kind of like a self-regulation of hormones. So this negative feedback happens between TSH and your T4, your T3, meaning that if you have, so okay, so let's see, Emily wrote high T3 or T4 will lead to low TRH and TSH. Yeah. So the main ones we really want to focus on are these hormones here. These are the ones that are typically going to be measured in your thyroid labs. I would know because I get these measured uh, every couple of times a year. Um, so yeah, these are the typical ones they'll measure. It's TSH more so than the TRH, not as much. Just TSH and your T3 or your T4, depending on whoever's ordering it. So the way it works is that, yeah, so every 3 months when on Lebo, which is what I'm on right now. My third month's actually my first time on it, and I get to get my labs drawn again at the end of this month. What? Okay. Yeah. So typically, when you have a high, typically kind of like the high T3, T4 is going to cause your TSH to be lower in order to compensate for that. Essentially, your body says TSH gets released to release T4 and T3, but when they're high, your body knows that it doesn't need to keep stimulating the hormone, so it lowers TSH. Does that make sense? So it's your body just making less. It's made. And then likewise, if you have a low T4, T3, it stimulates your pituitary gland to release more because now there is a need for it. There's a need for these hormones, so your body's going to go ahead and make more TSH to try to get it going. Okay? But that's the basic idea there. That makes sense? Any questions on this?
Diego, I have a question. So when you're hypo, is all three of them low or just the T3 and T4 low?
So when someone's has hypothyroidism, they're going to have a high TSH, and then their T4 and T3 are going to be low.
Okay.
Hmm.
Right. Thank you.
Yep. Anything else with this? Let's see. So, talking about the thyroid in particular, it just kind of some simple information regulates the metabolism. So the way your body breaks down proteins, fats, carbohydrates, um, has a has effects on the heart, or at least the thyroid hormones do. So I guess I'll write that in under thyroid hormone instead of under here. So we'll kind of go over there. Trying to see if there's anything else that's important, just specifically with the thyroid here. So there's like some extra information you guys get, like um, that's made of iodine. I guess I could say that. That's more like the thyroid hormone. Yeah. Just see if there's anything else here you guys might. Yeah, I feel like that's a little bit more to do with the thyroid hormone, like specifically. So I wanted to write that here. So I guess I'll do it here. So like you said, thyroid hormone in particular regulates the metabolism. It's also going to have an effect on the heart. So, more thyroid hormone, aka T4. I'll just do T3 is the active, so I guess we can talk about that. T3 is the active. T3 is active hormone. More T3 will lead to tachycardia or like increased heart rate, and stronger, more rapid contractions. So that's why when we talk down later of someone having a thyroid storm, that's why you'll see everything go up, temperature can go up, and all that other stuff. Something else that can affect your respiratory rate and drive. Essentially, your thyroid hormone, when it's really active, will make everything go up. So that's kind of how I like to think of it. Everything goes up, temperature goes up, heart rate goes up, respirations go up, GI motility goes up. So that's like a good way to think about it. Um, I don't think anything else here is particularly needed. Here, maybe if there's anything extra. Yeah, I guess the only thing that'd be here would be like the difference between the different types of thyroid cells, but I don't think it goes that deep on it. Like the follicular, parafollicular, yeah. So I'm not gonna really include that there. Um, okay. So here, your TSH for an adult, your normal values are gonna depend on what kind of units they have. This is the one I see most often, like zero point 0.3 to 5. And the units are kind of weird. It's like, I think micro units, not micro units, micro units per ml. Your T3, I guess I should write it down here. Well, I kind of wrote it here, so it's good. T3 is your active, your T4 is inactive. So typically, your body makes T4 first. Your body then, when it needs to use it, it will convert T4 to T3 inside the cells. But again, it's not the most important thing to know. Um, just maybe I'll do this, and then let's say T3 is made of iodine and protein molecules. So the important thing there is that you know that there's an association with your thyroid and your iodine. I also don't remember the lab values being too important for the test, if I'm being honest. But I could be. Do you remember if it was really relevant to know specific numbers on all these, Kaylin? 10-question test, yeah. Maybe the TSH. Yeah, maybe the TSH. T3 and T4 not as much, but I'll just kind of write down the types of tests that they do. T3, T4. Some other diagnostics they can do is a thyroid scan. You could do palpations of the thyroid, ultrasound of the thyroid, all that other stuff. And yeah, so that's something we're going to talk about when we get to that. But so one of the things is that you can palpate to see if there is enlargement, but you don't want to palpate those that have a noticeably enlarged thyroid already because it can actually cause the release of more thyroid hormone. So if someone has a goiter, that's what the enlarged thyroid is called. So here we can see something like that. That's your goiter. Something like that. Something like that. Then we don't like it's very clear with just looking that it's a goiter. So we don't want to palpate it because we don't want to have more release of thyroid hormone, especially if the situation is that they're they have hyperthyroidism, then we don't want to release even more thyroid hormone. So do not palpate those with that noticeably have a goiter already. Gonna go. Okay. All right. Any questions on this so far? You guys understand the general idea of negative feedback? I think that's probably your most important thing here. Understanding that the values are going to be different in that way. Understanding that your thyroid hormone has an effect on your metabolism. It can impact the heart, make everything go up. Some of the tests they do is your blood serum TSH, T3, T4, do a thyroid scan with radioactive iodine. So let's see, radioactive iodine. Because remember that your thyroid hormones are made from iodine. So your thyroid is one of your few organs in your body that actually make use of the iodine. So we can be really specific with it. So that's what's gonna make the thyroid easier to treat when it's like a thyroid cancer because we can do iodine things to it and make it be like very thyroid specific. So yeah, radioactive is used. And then so I mentioned that we use radioactive iodine. Um, are we worried about radiation precautions with someone after a thyroid scan with the radioactive iodine? Yeah, so not with the test, but with the treatment. So when it comes to the thyroid scan, radioactive iodine, it's gonna have a short half-life. So we're not gonna require any radiation precautions or anything like that. When it's actual treatment, then we can think about it more. But if it's just the thyroid scan, then no. Short half-life, meaning it doesn't really last too long before it deteriorates. Wait, that is the wrong button. Okay. Okay. So any questions on this again before we move on to hyperthyroidism?
Can you explain the negative feedback one more time?
Yes.
Thank you.
Yeah, so the basic idea of the negative feedback is that you have one hormone stimulating the release of something else, and then the concept is that once this number one here, your TSH makes enough of your T4 and T3, the very presence of it, the existence of having a high amount of T4 and T3 causes your body to then back down on the TSH. So here you can see we said it once you do have that high T4 and T3, your body then says, okay, we don't have a need to keep stimulating the hormone, the thyroid. So we're going to lower the TSH because the TSH is the thyroid stimulating hormone, and TSH causes the release of T4. So once it's already high of the T4, your body says, okay, we don't need as much. So we make less TSH. But in the situation where we have low T4 and T3, your body says, okay, we need to make more. So we get more TSH so we can keep stimulating the release. Does that make sense?
Yes, it does. Very clear now. Thank you.
Yep. Let's see if I can write it down here somewhere. So TSH um, causes release of T4, T3, and the body adjusts the TSH levels um, when it doesn't see a need, or it just doesn't know when T4, T3 is high because it does not see a need to keep stimulating. Okay, just making sure that if you guys were to read this over again, like on Thursday or Friday before the test, you guys can still remember what I explained here. Okay, so now we're gonna go over hyperthyroidism. So how would you guys define hyperthyroidism? Is this like what goes on in it? Yeah, so you guys are already going over the labs, so that's great. So the labs, we're gonna have, yeah, we're gonna have high T4 and T3 because these are your thyroid hormones. Makes sense. Hyper means high or above, so thyroidism, condition of having high amount of thyroid hormone. So high T4, T3, and like we mentioned here, um, you will have a low TSH because your body decides that we no longer, oh, sorry, yeah, hyper. Yeah, so your body decides that we already have enough thyroid hormone. We don't need to stimulate it as much. So we're going to have decreased TSH because of that. And the definition is just kind of, yeah, exactly. That's a good one. So hypermetabolic, so like a high metabolism state due to excess. I like that definition a lot. Excess thyroid hormone. Perfect. And this is going to lead to an increased metabolism and stimulation of your sympathetic nervous system. I'll write that out. So remember, it has an effect on the heart, it has effect on your respiration. So I guess I didn't write the respirations part here, but I'll write it in. Ba, 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 ba. Yeah. So it's going to cause your CNS to be impacted. So CNS in general being impacted, we can think about increased respirations and heart rate. So again, it's going to start making things go up in general. Talked about the labs. And now we're going to talk about the manifestation. So I said, if you want to cluster it all down to something, it's pretty much everything speeds up. Okay, so what are some things that we can think about that are increased in hyperthyroidism? Some things that you guys can think about. Yeah, so we're going to have tachycardia. We already mentioned tachypnea, hypertension. Fever, good. Pretty much, yeah, increase in everything. Increased GI motility, which leads to diarrhea, abdominal pain, increased metabolism. Yeah, so we're gonna have weight gain or weight loss. Yeah, weight loss. Perfect. So kind of like in general, we're thinking about your um everything going up. So even like irritability, so like anxiety, irritability will go up. It focuses on cardiac effects. A lot of the time, yeah, it can have a lot of impacts on the heart. And another focus to really think about is your fever. That's actually a big deal because if you remember thyroid storm, you get to very dangerous levels of body temperature. Um, and speaking of, you'll also have heat intolerance. So you're not going to tolerate the heat very well. Another one, let's see, I'm going to go through the list here. I typed a lot. Good. Pretty much increasing everything, yeah. Fine hair, yeah, you can have some hair loss. Some of them minor, oh, maybe like over chronic period of time, you can have a hair loss. Something we mentioned is a goiter. So a goiter is not hyperthyroidism specific. You can have a goiter with both hyper and hypothyroidism, but it's something that can happen. So take a note of that. Yeah. So Caitlin says take a note of that. So not hyperthyroid specific, but present. So excellent. So the exophthalmos. So this is your bulging eyes. I spelled it wrong. I knew it. Your bulging eyes. You have fat pads behind eyes, pushing them forward. Don't say that. Oh, you that was a direct message. Okay, Caitlin, that's funny. Yeah, yeah, it's hard to. All right. When I post the chat logs, remind me to delete that part. It shows up on there. Yeah, but yeah, exophthalmos, it kind of looks like this. You kind of have that like 1,000 yard stare going on. Yeah, like this. Yeah, that 1,000 yard stare. Yeah, and it's not something, is this a reversible thing? So once we fix their hyperthyroidism, is this fixable? Yeah, so it's permanent. Permanent once it's permanent once.
Actually, it's not. They can get medication because we give a medication called Tepeza, and I've seen their
Hmm.
eyes go back.
Oh, really? Okay.
Yes, they make the commercial. It's called Tepeza, and it's for the bulging eyes. And they get it because a lot of people complain it hurts them. It's really painful for their eyes popping out like that. And so they give them Tepeza, and they get it for 6 weeks, and you can start seeing the eye go back, and it gets normal.
Okay. So I guess we could say instead it's not fixed with hyperthyroidism being fixed. So you have to do things outside of fixing the hyperthyroidism. Um, but you so you can do not fix, but can be with medications or surgical treatment. How about that? More accurate. But yeah. So the idea there would be then that you have exophthalmos, uh, hyperthyroidism. They fix your hyper like you're on medications for your hyperthyroidism. Your levels are back to normal, but your eyes will still be bulging unless you do the medication or the surgical treatment, like Rosemary said. Okay, kind of have a section here talking about it, I guess. Uh, so I'll put that here instead. Cool, nice, good to learn stuff here. So yeah, so you can do surgical treatment to decompress, uh, remove the fat. Or the medications like you mentioned. In general, want to protect the eyes. Um, like eye coverings, artificial tears, arti Facial tears. Let's see what else we got here. Reduce pressure on eyes, so head of the bed up. And I want to see if there's anything else that you guys can include on your manifestations. If not, I have a picture. This is one that's like in your PowerPoint, but I like this picture. I feel like I always I think of the person in my brain when I think about it, and it helps me a lot. So here you can see person has the heat intolerance. They're more irritable, have the bulging eyes, tremors. So tremors, anxiety, irritability kind of go together. Weight loss, muscle wasting. Yeah, I can't hear anything, Alexis. What else is a good one? Yeah, that's pretty much it. Isophthalmos seen in general with hyperthyroidism or more specific to one of them. I imagine that it's yeah, it's just hyperthyroidism in general because your Graves' disease is autoimmune, but it leads to your hyperthyroidism. But according to Google, actually, it's especially common with Graves' disease. Hmm. All right, so that's an interesting thing there. So look, learning new stuff. But again, not hyper important. Their main thing is going to be really your understanding what happens when you're hypothyroidistic. So just kind of understanding this part here that everything speeds up, your management for it, being able to understand what a thyroid storm is, understanding how your labs would be. So understanding that negative feedback that we talked about. So basically your negative feedback is just saying this is high, so this other one's low. While if you look at the other condition, we'll see that this one will end up being high and this will end up being low. Okay, so yeah, just in general, everything speeds up. Perfect. And then Graves' disease. So we mentioned this. This is an autoimmune condition. So this is autoimmune disease that leads to hyperthyroidism. Thyroidism. All right. That's pretty much all you really need to know about it for this test. I don't think it really goes into really hard detail. I think on my personal notes, I have a lot of detail on it. That's because believe they didn't put much detail on that at all. And I was like, why not? But then I don't think it ended up mattering. So I guess that's why not, because it doesn't matter as much. Um, let's see. Let's just do general assessments first here. So assessments. So what are we assessing here on a person with hyperthyroidism? Some things you guys can think of. Very big one that Jackie mentioned is your temperature. So your temperature, heart rate, blood pressure, all those are good. Your temperature is going to be a very, very key one. So blood pressure, so vital signs in general. So your blood pressure, your heart rate. In general, I guess that's temperature is even, but falls into there as well. But in general, respiratory rate. Temperature is your really big one. Why is that? Someone mentioned weight. Yeah, weight's a good one. So intolerant, there's actually more to it than just intolerance to heat and cold. What else are we assessing for? What's a common complication with, yeah, so we are assessing for thyroid storm. Increasing temperature could be a sign of thyroid storm, which is a very big and dangerous complication. Um, yeah, what's the first sign of storm? Exactly. So an increase of even just 1 degree Fahrenheit is a cause for concern. It's both Fahrenheit wrong. There we go. I have a question. What is thyroid storm and thyrotoxicosis? They are the same thing. Yeah. Thyrotoxicosis. So osis means condition, abnormal condition of thyroid toxicity. So abnormal thyroid toxicity, in this case referring to too much thyroid hormone. So it is basically just a um, condition where you just have so much thyroid hormone, and we recall that your thyroid hormone has an impact on your heart, has an impact on your respiratory drive, your impact on your metabolism, on your an impact on your metabolism is going to affect your temperature. So overall, it's going to be having all these issues there. So your temperature is a really big one for this one. So I would highlight that. And then keep in mind that even just 1 degree Fahrenheit is a cause for concern. Like one plus, even just as small as a one can be a cause for concern. Yeah. Okay. Yeah. So weight, and then yeah, we talked about everything goes up because your thyroid is acting up and your thyroid increases everything. Everything goes up. So I just want to reiterate that everything goes up. Okay, so yeah, thyroid storm is also known as thyrotoxicosis. Okay, and your weight goes down. Yeah, the weight would be going down. So we're assessing for like weight loss because that is normal with your patients that have hyperthyroidism because their metabolism is going really fast. So these lucky people, well, not really lucky people, but they get to eat more, or they have to eat more. So there's going to be things, your management, your goal is going to be for them to maintain or gain weight. They're gonna need to have high calorie meals and stuff like that. Yep. I wish I could have high calorie meals. Yeah, so we talked about thyroid storm, so I'll kind of write you guys a definition. Yeah, that's pretty much, yeah. High calorie, high carb. They just need high calories. High calories is good. And to high protein would be also really good to prevent muscle loss. So yeah, that's what I would recommend for sure. Yeah. So prevent cachexia, which is muscle loss. That's muscle loss. You don't want them to have muscle loss. So high calorie, high protein is your way to go there. Okay, so the definition of thyroid storm, I would just call it a severe state of hyperthyroidism, typically triggered by an illness or another stressor. So again, kind of think about it like your autoimmunes, like your sickle cell, where stress is your big thing. Illness and stress are the things that cause a flare up. So in general, a lot of stuff gets triggered like that. Your illness and your stressors. So think about that. Sepsis, DKA, trauma, pregnancy, potentially life-threatening. It's an emergency. So what are your big manifestations with thyroid storm? Okay, that's definitely one. Fever. So your fever is your really big one. You can get temperatures to like 104 plus even. Yeah, you're gonna have hypertension for sure. What's a sign that you will see? So someone is in thyroid storm, what's something you might be noticing a decline of? Yeah, like an altered level of consciousness. They can have tremors for sure. So remember, everything is going up. So that includes agitation, that includes anxiety, that includes tremors. Just imagine someone just unable to hold themselves, just everything's going fast. So um, in my head, that also helps me think about the fact that they could go into a seizure, potential seizures. Everything's going fast. Seizures, we typically think of the tonic-clonic seizures where you're shaking and stuff. So in my brain, it kind of goes together. Um, a lot of sweating, so diaphoresis, dehydration from the loss of lots of sweat and stuff. They could even go into a coma, but this is kind of what I would include here. It's possible seizures and coma, agitation, anxiety, tremors, irritability, restlessness, increased risk of falling. So something that we might actually want to include to your regular assessments is a level of consciousness assessed for thyroid storm for a sign of decline in thyroid storm if they're having it. So just like, see how they are mentation wise. But again, your main thing is going to be your temperature though, and your general vital signs. So we can treat symptoms. So we can treat the symptomatic vital signs and stuff alongside the hyperthyroidism, um, treat the temperature, cooling measures, and all that stuff. We'll talk about that when we get to interventions. Um, yeah, again, other things that might happen here is abdominal pain, nausea, vomiting. Again, everything goes up, GI motility goes up as well. Any questions so far on this? Yeah, like nausea, vomiting, diarrhea. I can imagine that. Yeah, I can imagine that. And then I want to emphasize the fever is it can reach levels of 104 to 106 Fahrenheit. So very, very high. Okay. So just keep in mind the things that really separate thyroid storm from just a hyperthyroidism, especially going to be this really high fever. Altered level of consciousness is a big one as well. That really sets it apart. Because you can have hyperthyroidism, you can be having a lot of these conditions here. A lot of the tachycardia, the tachypnea, the increased blood pressure, but the altered level of consciousness and the high fever are like the two things that probably are more defined, and maybe also like more like bad diaphoresis and bad dehydration. You can still have both of those happening here. You can see the guy here, he's also sweating a little bit and having stuff like that, heat intolerance. But I would say these two are probably your major ones. So if you have to differentiate them, or they ask you a question where it's like, this is what's happening to the patient, what's going on, then you guys are able to answer that. Okay. So what are some interventions for this patient here? I see. Theron says IV beta blockers, anti-thyroid meds, and maintain patient airway. So yeah, of course you're gonna have your ABCs. So Alexis, levothyroxine is actually the thyroid hormone. That's actually what I take. So that would be for hypothyroidism. So you don't want to give them more thyroid hormone. So we're not gonna do levothyroxine. Yeah, propranolol is gonna be cooling measures is gonna be good. So you guys are writing a lot of good stuff, so I'll kind of write some down and I'll talk about it so that I can keep up with the chat. Yeah, propranolol is going to be one. So let's see. I'll write down what you guys are saying and then I'll kind of write it down. RAI. What's RAI? Oh, radioactive iodine. Okay, interesting. Yeah, the methimazole, PTU. Yeah, PTU. Okay. So keep in mind that with your hyperthyroidism, we don't want to give them regular iodine. If we're going to give them radioactive iodine to try to overload it, that's fine, but not regular iodine, because iodine is something that if we look at here, go back up here, your T3, your actual thyroid hormone is made up of iodine. So iodine can increase your production of your thyroid hormone. So when someone has hyperthyroidism, we don't want to give them iodine. So now that we got you guys a chance to answer, Lugol's. So Lugol's is, so that's the interesting thing. You guys learned about Lugol's iodine. That is actual regular iodine, but they give that prior to a surgery. And the rationale about it is that you're actually overloading the thyroid with so much iodine that it stops working for a bit. So the Lugol's iodine is pre-surgery to overload the thyroid so that you can do surgery on it. Um, yeah, that's why it's short-term therapy. It's used before the thyroidectomy. It's just a overload, and there's like a whole like we like did like some stat pearls thing. I looked at like stat pearls. I was confused about it. Here's the information on it. I yeah for yeah just looked it up. When I took my notes on it, not necessary to know. It's extra information, but that's the rationale. So there's some sort of effect, but so some scientist, Wolf Chaikoff, named this effect, which is that you overload them with so much iodine, it stops working, the thyroid temporarily. Okay, and then I'm looking at Maha. It says in the lecture PowerPoint, we have that we need to follow radiation precautions for a few weeks after getting radioactive iodine. So let's see. Kaylin, do you mind? Could you look that? I want to see if we have the same, if our PowerPoint differs or if their PowerPoint differs from what we had. Could you look that up? Oh, Maha up above said that in their PowerPoint, um, they were told to follow radiation precautions after getting radioactive iodine. Or unless I guess it might depend. Are you referring to your thyroid scan or a different one? Or just like radioactive iodine for treatment of hyperthyroidism? Because I can see where you might be talking about in that sense. The thyroid scan is like a small amount at a time, and then your treatment with it would be different. Yeah, in that case, that would make sense because you're not just doing a one and done. So I guess here, I'll make sure that it specifically says for thyroid scan. How about that? So in the thyroid scan specifically, we don't need radiation precautions. It's like a one and done. Yeah. So that's the RAI as opposed to the thyroid scan, which is just again a one and done. So let me just try to organize everything here. So we mentioned ABCs as per usual. Um, Airway can be compromised. Altered level of consciousness can lead to compromise as well as the goiter. So remember that they have that big goiter thing going on, which can lead to obstruction of the airway. Because look at that thing. Look at that. So it's possible that that pushes down on your airway. This guy does not look like he has a great time breathing. So yeah, so the goiter and altered level of consciousness can lead to airway obstruction. So you want to think about your ABCs always. Talked about your anti-thyroid medication. That was a second head. Yeah, kind of, huh? And your anti-thyroid medication is methimazole, otherwise known as tapazole, and the PTU, which is propylthiouracil. PTU. Spelled it wrong, but we'll be okay. Yeah, propylthiouracil. Okay, there we go. So these are your anti-thyroid medications, and it's worth noting that your anti-thyroid medications are not fast-acting. So, a reason why we also are focused on the symptomatic part of it is because your anti-thyroid medication is slow to get going. So we're still gonna do this other stuff. We're gonna do management of heart rate and blood pressure. Your propanol. You remember your beta blockers affect your heart rate and your blood pressure. So we're gonna give propanolol because it's a beta blocker. Yeah, cooling measures. So we can do cool blankets and stuff. So let's see, to explain. Yeah, it takes time to work. That's why you get lab testing every 3 months. So it's for thyroid storm. I guess you mentioned it, but yeah, people with thyroid problems every 3 months. Antipyretics. So one thing that I don't know if it was emphasized or if I'm extra, but something that I had written down is that you specifically, yeah, okay, so it was talked about. Yeah, so we want to do um, non-aspirin antipyretics. So we don't want to take aspirin for your fever, but we can take like Tylenol. Yeah, so the reason for that is because, like Kaylin mentioned, your salicylates, so aka your aspirin, is going to increase your hormone levels. Um, so I'll put like antipyretics except aspirin. Aspirin increases thyroid hormones. Okay. So something else that you guys, actually you guys didn't mention it, but extra stuff here that goes into the management includes your glucocorticosteroids, because it's glucocorticoid steroids. Your body's going into overdrive, and that includes kind of like a general inflammation response, like an overactive immune system as well. So your corticosteroids is to decrease inflammation and slow down an active immune system and overactive immune system. Something else that we can do is, remember we mentioned that the patient is going to be diaphoretic and have issues with dehydration as well. So IB fluids and stuff, IB fluids and electrolyte replacement due to insensible losses from diaphoresis from your sweating. We remember that from 212. Are the anti-thyroid meds lifelong? Yes. Yeah. Especially if they're gonna be if it's gonna be happening from um well, like the context here would be this is someone that has oh, okay, yeah, there's some context where changes would be like after you have your thyroid removed, then you're not going to need anti-thyroid meds. You don't have a thyroid anymore. But in the context of someone that has hyperthyroidism, especially from like Graves' disease, which we know is autoimmune, then yeah, they're going to be on anti-thyroid meds for life, unless they need, yeah, unless they need to get their thyroid removed. But then if they get their thyroid removed, now you need the opposite. Instead of having things to block your thyroid from releasing hormones, now that you don't have a thyroid, you actually need the thyroid hormone. So it kind of um, changes over to that. Um, but it'll make sense as we talk about when we actually talk about the thyroidectomy part of it. So something else is when we mentioned you have anxiety, agitation, possible seizures, comas, all of these things in general. When you think about like brain overstimulation of brain, you want to think about decreasing stimuli. So things you can do is cluster your care. You want a quiet room and discourage the patient from walking around, especially if they're altered mentally. We don't want them walking around and falling. They're gonna die and it's gonna be over. Yeah, dimming the lights is good. Quiet room, dim lights. That's a good one. See what else we can do. Cluster care. Talk about anti-thyroid medication. And I'll kind of point out that these are takes a few weeks to take effect. So in the meantime, we're gonna be making sure that we cool them down, manage their high heart rate and blood pressure with propranolol. Glucocorticosteroids can decrease the inflammation, give them IB fluids because they're losing it. Make sure that we do decrease stimuli. We don't want them to have a seizure or anything like that. Some other things here. These are two interventions. Oh, interventions for this is interventions for that one. Yeah. So Kaylin mentioned specifically like your propranolol is very important for thyroid storm because again we're going to have very high blood pressure, very high heart rate, signs and symptoms of hypo. Over time, for someone with hyperthyroidism, yeah, you want to make sure um, that yeah, they don't go backwards. Just like with your fluid therapy, someone's dehydrated, you're giving them IV fluids. You also don't want them to then go the opposite way and then become pulmonary edema. Yeah, so you want to assess for overcorrection on both sides of the spectrum. Yeah. So let's see. Yeah, so this is important here as well. So propranolol is like a very important drug for thyroid storm because we need to really manage those heart rate and blood pressure. Okay. Uh, uh, um, so other interventions we can do is EKG for possible dysrhythmias because again we said that thyroid hormone can affect the heart. So we can make it go into overdrive. Do we slowly wean off the propranolol until the antithyroid med kicks in? So the antithyroid meds takes weeks. So um, does it take weeks actually? Or does it take a few days? Let me see. I mean, I know, yeah, it's mainly propranolol mainly for thyroid storm. So we're not really gonna get propranolol with normal hyperthyroidism. Propranolol for thyroid storm. So I kind of want to make that more obvious that they're separate. So I'll kind of do this, make it its own little section here. Um, and then have this added on to just the hyperthyroidism. And then have thyroid storm be its own thing. Okay. So right now we're just talking about thyroid storm. Okay. So information here is that you can have your heart rate in the 160s to 170s. So that's why you're gonna really need to manage that. See what else do I need to talk about here? Guess we can do general hyperthyroidism here. Right now we were just focusing on storm because storm is really important. But for general hyperthyroidism, we already had some that we talked about. Um, yeah, anti-thyroid meds. We can just copy paste that. Yeah, the cardiac monitoring would be here in thyroid storm for EKG. But right now we're just gonna copy paste this. So it takes a few weeks to get effect. Um, labs are labs for TSH and T4, T3. Are going to be drawn every 3 months. Lubricating the eye with eye drops. If you have exophthalmos, then yeah. Non-pharmacological, you do like eye protection if they're exophthalmos. However you spell that. Let me see what else I can think about. Rest in general, comfort, rest and comfort, eye protection, head of the bed up. So nutrition stuff, no stimulants. Stimulants are gonna also make things go up. So, caffeine, that's your favorite stimulant. You want high calories, small frequent meals. You want to avoid iodine. So avoid iodine-rich meals and goitrogenic foods. So foods that cause goiter, and I'll list them in a bit. So some things that you want to avoid. Um, Soy, so like tofu and stuff, chocolate, cabbage, spinach, seaweed, seafood, seaweed, dairy. Let me see. Um, doesn't say it has to be avoided, but maybe with some consideration. Anything else you can think about, Kaylin, for foods to avoid?
What about seafood?
Yeah, seafood, seaweed, seafood, seafood. That makes sense because it's full of iodine. So seafood, kelp, and stuff, turnips. But yeah, these are some of the ones that you might want to think about. So just think about them. Just think about them. Okay, so then we're gonna go. So let's see. Anne says, is there a certainty their neck could be positioned? What does that mean? What do you mean by that? Oh, after surgery. Okay. Um, yeah, so you guys really like RAI, so radioactive iodine. So yeah, when medications are not effective, surgery is not an option. Long-term control of hyperthyroidism is needed. Radiation precautions due to being long-term. Okay. And then the surgery. So what's the surgery called? And we'll all go over the surgery. Thyroidectomy. Yeah. What's the indications for it? Okay. Do we automatically go for a thyroidectomy with someone with Graves? When would we say, okay, we need to do surgery? It's a last resort. Yeah. So it's a last resort. Yeah. So we can do partial or total. So I'll specify that. There's total and partial. So when do you think we would go, okay, this is our last resort, but what did you already try or what is going on that you want to do surgery on it? Yep. So medications are not effective. Okay, what else? Okay, I like that one. So goiter is causing airway breathing issues. Perfect. That's pretty much what I was looking for. It's just your treatment, medication, RAI not effective. Goiter is causing airway breathing issues. Jennifer asks, how long, months of taking meds or weeks? I would imagine it's probably more of a long term. Let me look that up 'cause it's not like a super important thing for the test. Um, Yeah, it says it varies typically maybe a few months, like half a year to a year. Like obviously it's last resort, so they don't want to go right into it. They're gonna try their best to adjust your medication. Yeah, with ca cancer, of course. Yeah, they're gonna do their best to um not make you remove your thyroid and live on thyroid hormone for life, if possible. But yeah, okie dokie. Is there any questions on anything we talked about so far? Otherwise, we'd be going straight into thyroidectomy and then a small little thing on hypothyroidism because the main focus is on really just hyper and thyroid storm. Any questions? And if you have questions, ask Kaylin. I have to go to the bathroom real quick.
Bro, what? Wait, hold on. High key, I was eating some food and then all I heard was my name. What's going on?
You went on a bathroom break and you're in charge.
Oh God. Okay. It feels like it feels like when you're all of a sudden like in charge of like super important thing. I'm like, oh God. Okay. Um, what's going on? Aesthetic problems, cancer, CA plus situation. What does that mean? I read it as like calcium, but I'm not sure. And where the cookie's at. Ooh, forgot I was talking to y'all about that. I was gonna make them actually this week. Hypocalcemia. What part are we on? Are we on the thyroidectomy still?
No, before that, I think he was gonna barely get into that one.
Oh my God. I felt like we were bouncing around at one point, so I'm like, I'm kind of confused. So I'm like, I'm a little confused on where we're at exactly. What was the question that you guys were previously asked?
I think he was asking about why we would want to do a thyroidectomy, and that's where we're at.
Okay, got you guys. So why would you want to do? And then I see you guys were saying cancer, the aesthetic problem, psychosocial. I mean, at the end of it, that is a big point for the person themselves, but your biggest issue is going to be your airway. Let me go to that part in
Hello, I'm
the
back.
notes. How could you do this to me?
What?
I was trying to get a snack, and all of a sudden I hear, "Oh, you're in charge." I was like, "What?" I
You're
didn't even
trying to
know
get a
what was
snack?
going on.
Well, did you get? You can get your snack now, I guess.
Well, I already got it.
Oh, okay.
I just didn't know what was going on. I was trying to figure out what the last question was this whole time because I went to go get a snack.
Yeah. So what are we asking about here? Someone
I don't
asking.
know where you let off.
Oh, we just talked about indications for surgery, thyroidectomy.
Okay.
Um, so we're talking about hypocalcemia. So there is a factor with calcium. So I kind of left it out because from memory, it was slightly it was extra until like surgery. So when we get to surgery, that's something we think about. But I think there's like a calcium element to it in general, and I guess I can give you some context on that. Yeah, so your something that you might find in your labs is calcium is increased. So let's see. So increase. So we can have hypercalcemia, and the gee, isn't it hyper? Yeah, it's hypercalcemia. On it with your hyperthyroidism, hypercalcemia, hyperthyroidism. Mm. Yeah, and the reason for that is a very complicated reason that I needed outside source to understand. But if you guys want it, it's very extra. It's very extra. Your calcitonin, yeah, it will also increase, but that's kind of what this are. Basically, the idea would be your calcitonin increases. Calcitonin puts calcium in the bones and outside the body, so you would think it would end up having decreased calcium, but overall you actually have increased calcium, which is interesting. Sometimes I get lost on what is something I looked up entirely on my own and something that's what you guys have. So I wasn't sure if the calcium part of it in terms of the labs was something that I put on my own or was it already there? What can you guys tell me on that? What do you guys think? You guys remember? Let's see what else I can have on you on calcitonin. I was asking, yeah, I was asking about when it came to the labs for hyperthyroidism, did you guys have hypercalcemia slash increased calcium in there, or was that something that I looked up on my own? Because sometimes I can't remember if what I have written down for reference is something that I looked up entirely on my own, or if you guys had it written down as well.
I think was morely talked about like after surgery to watch for signs of hypocalcemia. So
Mm-hmm.
looking for the Trousseau sign and the Chvostek sign, yeah. But
Yeah,
it was
so
mostly after the thyroidectomy to watch for. But yeah, I don't think we had anything, at least as far as I know, for hypercalcemia. It
mhm.
was mostly about the hypocalcemia after
Yeah, after surgery,
thyroidectomy.
yeah,
Yeah,
after
that's what
surgery it's
we had.
hypo, but before just like as a normal thing, you have more hyper. But I guess that's extra, so I'll keep it off because I don't want to confuse anyone. Again, like the thing I found was like completely extra information. The hypocalcemia is a post-op. So again, don't want to confuse you guys, so I'll leave that off. That's just something I rabbit holed and found. Um, but yeah, let's see. Okay, so any questions on everything? I want to make sure that it's as least confusing as possible because I know we kind of went thyroid hormone and then started talking about sorry, we started going about hyperthyroidism and then started talking about thyroid storm and just kind of deep dived into thyroid storm before finishing out the interventions for regular hyperthyroidism. So I want to make sure that it's no one's confused at all so far. Is there anyone that's confused on that jump? Because we did kind of go back and forth on that. No one's confused? Okay, that's good. Okay, perfect. Cool. So hopefully, you guys will see from the thing it will make sense. We go hyperthyroidism, talk about labs manifestations, assessments, and then here, interventions for general hyperthyroidism, like your anti-thyroid meds, your nutrition, radioactive iodine, and then when to have surgery. And then we go into thyroid storm, all your important manifestations you guys should go learn or remember. Remember, propranolol is very important because you have such high vital signs. You need to manage it properly, but you're also worried about the airway. Awesome. And then again, just keep this in mind, just in case, keep this in mind. All right, cool. This one in mind. Okay. Anyways, moving on. Thyroidectomy. So what are some pre-op things that we do with thyroidectomy? We kind of talked about it a little bit when you guys asked me about the Lugers, whatever you pronounce the guy's name, little iodine thing. Luger's iodine. What else? Yeah, Lugol's, that's what it is. Lugol's iodine. Give anti-thyroid meds to get them to a euthyroid state. Let's see. Sorry, I'm trying to organize myself here. I wanted to include one more thing here. Talk about Kaylin mentioned it, but yeah, lithium, last option. So let me see what you guys mentioned. So the Lugols, yeah. Ba-ba-ba. Yeah, so you can do Lugol's iodine. So I'll kind of start talking about it now. Once we find my spot here. So that's something you can do. You can do Lugol's iodine to overload the thyroid if need be. And it also has another thing. It does another action as well. Do you guys remember what else it does?
Keep from bleeding, hemorrhaging.
Awesome. Yeah, exactly. It decreases blood flow as well to help reduce bleeding after. So it's got two double purpose and turn to a euthyroid state. Exactly. Cool. So the Lugol's iodine is something that we can do there. Perfect. Yeah, and then just again making sure I have step. Yeah, perfect. All right. Yeah. Need to make sure nothing is confusing. I don't want any confusion. Boom. Probably organized better like that. Okay. What else can we do pre-op? Just like general things that you might think about. Yeah, like the MPO, informed consent, just like your classic. Just like some patient teaching. Yeah, someone said teach deep breathing exercises, how to support their neck. Yeah, all that good stuff, just like your teaching, patient teaching. Yeah, yeah, exactly. Ensure stable, perfect. Okay. So now what is your post-op? So now we have removed or either partially or totally removed the thyroid. There are some differences, of course, between them. We can talk about it here, probably just kind of here. Total versus subtotal. So what's gonna happen? What's like the main differences between total and subtotal? So someone gets a total. What is something that we can expect to happen? No longer have a thyroid, complete lack of thyroid now. What do we do? How do we keep managing their condition? Do we um
You
keep
put them
them
on
on?
thyroid medicine.
Exactly. So do you remember the name of that one?
Synthroid.
Synthroid. I take that. Thyroid replacement for life. Because again, no thyroid, so you're gonna need that. So it's levothyroxine. Okay, Synthroid. And if it's subtotal, do you also need to take Synthroid guaranteed?
I believe you do.
From your experience, you've seen that most people are placed on it?
No, I didn't experience that, but I just think you do because I think they'll just run your labs and stuff because they can give you more or give you less. So I think you do. I'm not sure.
Yeah, so it's kind of depending on the person, depending on how much they remove as well. But subtotal is going to be the preferred. So we'll go preferred. If possible, we want to remove as least as possible. And it's kind of a may or may not need thyroid replacement. Depends. Again, they might take some, they might not need it. Depends on how big, I guess, the cut is or how much they remove. Depends on the person. So basically person dependent. But with your total, you 100% need thyroid replacement for life because you no longer have a thyroid, and if you don't have a thyroid, you're gonna die. Or well, if you don't make thyroid hormone, you're not gonna live. You need it at some point. But yeah, but if you get a subtotal, then your body might still that part of your thyroid that's still left may still be able to produce some T3 and T4, and it might be enough to get you by. Okay. Any questions on that? Did they ever try a partial first? What do you mean? That's the preferred surgery, or what do you mean?
Sorry if you hear my kids in the background.
Oh,
Like,
no
do
problem.
they try to remove just part of the thyroid to see if that alleviates the hyperthyroidism, or do they always,
Oh, I see what you're saying. I see what you're saying.
you know what I mean? Like,
Oh
I
yeah,
know with like a hysterectomy, they try to keep part of your reproductive system so you don't have to be on hormones.
Oh, I see what you're saying. I see what you're saying. Um, based on what we go over, they just say you get it done based on their condition. So if it's cancer or depending on the med therapy failure, goiter, obstruction, depends on how bad it is, they might do one or the other. I don't have a direct answer for that. I'd have to look it up. But yeah, subtotal would be a part of it. So subtotal, also known as like a partial. But I imagine that would be the intent. The intent would probably be to do a partial if possible, unless it's to the point where you must do a total. Again, it probably just depends on the acuity, but it's not gonna be on you to know that for test. It's just kind of understanding that it's depending on the condition, but you don't really have to, you're not the one making that decision. So yeah. Okay, so now they got their surgery done. What are some post-op care, not counting the complications? Complications we'll talk about right after, but the post-op care in general, what are we thinking about? What's your number one thing? Vital signs are important, but there's one more thing that's even more important.
Is it the gag reflection? The gag reflex?
That's definitely important. The gag reflex kind of goes with ABCs, airway and stuff. So yeah, I would say that's one of it for sure. It's your airway. And this one you're gonna, yeah, pretty much your airway is gonna be your number one. So having a gag reflex is gonna be important. So I definitely like that. Want to make sure patient has a gag reflex. Something that they mention is to have a trach kit in case of need, just in case. So Alexis mentions potential risk of a thyroid storm or something can happen after surgery. Honestly, I don't know about anything with that. Yeah, airway because of inflammation. Inflammation could obstruct your airway. Because remember, think about where your thyroid is. It's pretty much, if you were to have a large amount of inflammation there, it would obstruct your airway, kind of just like the goiter might um, obstruct the airway. That's kind of the reason why you're doing that.
I think for the thyroid storm thing that Alexis was saying, I feel like I read that somewhere too. I don't think it was a part of what was given to us in lecture, but I believe it can happen with your partial as there's like manipulation of the thyroid itself, and if you leave some of it behind and it's manipulated too much. Yeah, that's my girl nurse Sarah. I was like, I knew I heard it from somewhere. Manipulation can cause thyroid storm in the end. That's rabbit holing a little bit too. It's not too deep on what's expected for you guys to know, especially because it's a 10-question quiz. Like that's the hardest part of that is 10 questions and it's only thyroid and gallbladder. So it's like, what we got to pick out like what's going to be the more important things here. I don't like those 10-question quizzes. It hurts my heart a little bit. But yeah, I believe that is something that could happen, but typically after a partial.
That makes sense to me. I mean, makes the most sense. If you don't have a thyroid, it'd be kind of weird to have a thyroid storm, but it makes
I would
sense.
call that a miracle.
Okay, so some other things, again, general, like assess for complications. So one of them will give you like bleeding. So we do the Lugol's because we want to reduce bleeding, but you can still have bleeding. Mentioned stridor. So yeah, stridor is something that you can have. Assess for stridor. So that's a big sign, that kind of like when we went over in the skills lab last week. That's a big sign of your yeah, cool. You mentioned this one. Big sign of big airway obstruction. That's an emergency, so we got to really make sure that we assess for that. Voice changes can be a sign of an closing airway as well. Hoarseness, yep. So these are signs of closing airway. Some other things that might be showing you signs of airway is like dysphagia, drooling, tetany. So tetany is going to be kind of like muscle spasms almost. So not tetanus, that's different. So tetany is like yeah, like involuntary muscle contractions. That's gonna be one of your things for hypocalcemia. Yeah. So if you guys have done Kaplan, that one comes up a lot. I think I remember seeing it come up a lot on stuff that was unrelated. So it was always like, I don't even know what that is. Choose metal. I don't even remember what that question is, but I think we all know what I'm referring to if you guys are doing the Kaplan. Yeah, so here, so hypocalcemia is one of your possible complications, tetany as well. So tetany. Awesome. So what are some things that you can do to assess the hypocalcemia other than tetany? So like specific signs for hypocalcemia. Yeah, the Vostok sign. I learned that the CH is silent. And Trousseau. Yeah. So the Vostok sign is you start tapping the facial nerve and then they cause them to twitch. Trousseau sign is something you can see when doing blood pressure. You can see them having little spasms with their hand. Tingling in the mouth is just another one. Oh, that's a good one, Kaylin. The CH and Vostok for cheek. I like that. So hypocalcemia. I'll post. Oh, that didn't look too good on that one. Maybe I'll do it right here. It's kind of overly big. It's just a nice little picture that has the signs and stuff. Why won't you go in there? Ah. Oh, I don't like the empty space. Is this legible, or do I have to take the L on the empty space?
Bro, are you okay?
Well, no.
I just take the L. That is so tiny.
Oh.
Bruh,
Okay, fine.
take the L.
Okay, you guys are gonna have empty space. It's gonna look ugly.
Ugly, but now it's legible.
Okay, but yeah, here you go. That's a picture that's really helpful to remember it. So if someone does have hypocalcemia, something that can be involved here in your post-op care is having calcium gluconate on the bedside to treat bedside for hypocalcemia possibility. So just like you might have a trach kit in case of an impending airway closing, you can have your calcium gluconate for your potential risk of impending hypocalcemia. So other than hypocalcemia, we already mentioned bleeding, so hemorrhage possible. Respiratory distress makes sense. Strider, really keep in mind that Strider. You need to call rapid response. Kind of what we talked about in Skills Lab. Rapid response. Yeah. Hypocalcemia, I'd probably put this as number one. Your airway is going to be your number one complication, hemorrhaging hypocalcemia. Yeah, we did actually mention the thyroid storm and laryngeal nerve damage. So thyroid storm due to physical manipulation. Probably more common with your partial. And laryngeal nerve damage lead to a hoarse or weak voice. Okay. Any confusion or questions on anything so far? We're almost done with thyroid. Very close. I didn't realize thyroid was so long either. Sorry, hypothyroidism is super short because they hate me. I'm just kidding. But yeah. We'll kind of just do we'll just do a simple definition here as kind of a decreased metabolic state due to low levels of thyroid hormone. So basically the opposite. If hyperthyroidism is everything speeding up, then hypothyroidism is everything speeding down or slowing down. So, and then again, this is going to have basically the opposite labs as hyperthyroidism. So you're going to have decreased T3 and T4. And because of that, your body wants to do more TSH because it wants to keep trying its best to stimulate the thyroid to actually work. So this one also has an autoimmune condition called Hashimoto's, which is what I have, but they don't mention it. But just fun fact, I guess. So for your manifestation is everything slows down. So basically think about all the opposite stuff that we had on the other one. So we said weight gain on the last one, so now it's weight loss. We said heat intolerance, so now it's cold intolerance. We said tachycardia, so now it's bradycardia. We said tachypnea, so now it's bradypnea. We said increase GI motility, now it's decreased GI motility. So instead of having diarrhea, abdominal pain, it's constipation. Is it weight gain or loss? So it's gonna be weight gain. Oh, well, I kind of trolled. It's my bad. I trolled you guys. It's weight loss on the other one, weight gain on this one. Thank you for catching that. I messed it up. I think I said the right thing and then typed the wrong thing. Yeah, you can all, and then this one you can also have a goiter because we mentioned it's not specific to either one. It can just happen. There's also something called you also have dry skin, fatigue. So instead of having anxiety, agitation, and all that stuff, you'll have fatigue instead. So basically all the opposite of everything we talked about prior. So it's kind of nice that it's kind of all the opposite. Facial and eyelid edema, yeah. So that's the moon face, periorbital moon face. So you have facial eyelid edema. And you have something called mixed edema, which you have kind of also mentioned here. But this is a thick skin with non-pitting edema. Where'd you even find that? I like that a lot. Oh, it's a hidden one. Okay. And then I have another picture that goes along with that as well. So there you go. This guy's cold. He's got a dull blank expression. I guess we can put that in here. So even the expression is slowed down. It's halted. It's decreased. Apathy, lethargy, aka fatigue. They have dry skin, weakness in general. I wish I had anorexia. Damn. Uh, receding hairline. I don't think I have that, but I don't know. Um, other stuff here. Pretty much this picture's pretty good. Uh, yeah. So then, any questions on this? Okay. So myxedema coma. This is essentially advanced hypothyroidism. Everything slows down um, to the point that thyroidism that you have pump failure. So even your heart is slowing down. They call it a flabby heart. Pump failure. You have everything again, everything goes down. Your cardiac output goes down. Oh, I forgot to put hypotension. Instead of having high blood pressure, you have low blood pressure. You have pump failure, so that means decreased cardiac out. You have decreased cardiac output. You have decreased blood pressure. You have decreased heart rate. So again, everything goes down. Some other things that can be included. Hypoglycemia. So again, everything goes down. Hyponatremia, everything goes down. Hypoventilation. And you can have altered level of consciousness, which makes sense if it's called a coma. But you can see how everything is slowing down here. So your main management, what are some managements you guys can think about for, is this for regular thyroidism or did I put it for myxedema coma? I think this is just for myxedema coma. I need to stop doing that. I did it to you guys last time, so I won't do it again. I'll just do management of hypothyroidism. So general hypothyroidism, what is some stuff you guys can think about? Not myxedema coma just yet, just hypothyroidism. Yes, levo. Okay, synthroid. It's basically synthetic T4. And it's patient specific. Dosing is patient specific. Yeah, you want to do iodine-rich foods.
What about hydration?
What about what?
Hydration,
Hydration? Let me see.
because you said their blood pressure is low.
I see that, yeah. I think in terms of what we were told in class, there's nothing really that was specified for it, but I drink a lot of water, so maybe there's something to that. Yeah, thyroid medication, anti-stomach. I wake up at 5:30 to take it, and then have breakfast at 6:30. Right? Yeah, it's slow to work. Takes a little bit. It has interactions with decreased absorption, with calcium in particular, and maybe like soy. You obviously want to assess for hyperthyroidism. Um, because you go the other way. Anything else? Yeah, take at the same time every day. So to work, take at the same time every day on empty stomach in the morning. Avoid calcium, so that means no fiber, no milk. Increase rest if possible because you're tired. Yeah, some heating. Just like stay warm. Oh, actually, you're right. You're right, Rosemary. It was just lower down on what I had here. Yeah, the increase. Oh, because they're constipated. That makes a lot of sense. I do be drinking a lot of water. Yeah, and we have to do a low calorie, like low everything diet and exercise, and all while still being the same amount of hungry. Mm, mm, mm. Um, Okay. So now that we kind of talked about general hypothyroidism, myxedema coma now, I'll just kind of talk about it. It's just you're kind of like your surgery. You want to maintain the airway, um, assess vital signs and stuff. All the everything would be decreasing in this case, decreasing temperature, respiratory rate, blood pressure, heart rate. You take levothyroxine IV. You take glucagon IV for hypoglycemia. Keep patient warm. All that stuff. Here we don't really need this. Here. Okay, so increase. Yeah, I want to assess the level of consciousness. Okay. All right. Finally, we get to gallbladder. Is there any questions so far? Anything on thyroid? Damn, it's longer than I thought. The worst part is you guys had this and mailed you in the same day or in the same week. Damn, that's tough. Yeah, I remember. That is tough. I'm glad that's over. I know, that's the worst part. The worst part is they put neuro at the end of every med search. It's always at the end. So it's like the one thing most people know the least about because it's always at the end. And it's just crammed on for the final and then forget about it. Okay. So gallbladder. So I just kind of wanted to have some general gallbladder information here. We'll just read through it, no more than that. Your biliary system, liver, gallbladder, pancreas. Here's a picture of how everything is going on. Your gallbladder's right here. Your gallbladder stores bile. You use bile to help digest fats. It mentions here as well that the cystic duct is a common place for gallstones, and people can have gallstones without having cholecystitis. Some people can just have gallstones without it being like symptomatic or causing issues. But cystic duct is a place for it to get stuck, common bile duct as well. So if you can see here, the cystic duct here, that's going to be where you can have your cholecystitis happening because it gets stuck in the cystic duct. But you can see here, it's connecting to this one duct here. And the common bile duct is another place where gallstones can get caught in. And you can see that if you have obstruction here, how it can potentially have an impact on your pancreas and also your liver, because both of those are kind of connected to this common bile duct. So once we start talking about cholecystitis, you'll see that there can be liver and pancreas involvement with it. Okay. Now let me see if I have any tables to give you guys for, not for thyroid, but I do for gallbladder, so that should be helpful. Okay. Do we have time? Yeah, we'll have time. We can do it. Okay. So there's a few different types of cholecystitis. Cholecystitis just means inflammation of the gallbladder. You have acalculous, acute, and chronic. Acalculous is A without, calculus meaning referring to stones. So this is cholecystitis without presence of stones. So that's the definition of that. So we can do that. It's acute inflammation of the gallbladder without stones. Okay. What are some manifestations of your cholecystitis? How would you define it? So you don't have stones, but your bile gets a certain way. How would you describe that? And then think about some causes that you guys can tell me as well. It's like a sludge. Yeah. So if you guys have ever seen someone do a diagnostic on the gallstones, you might have seen like sludge. I've seen like a few times where on the diagnostics it mentions, oh, there's sludging in the gallbladder. That's what it's kind of referring to, like the bile kind of gunks up, so it becomes sludge-like bile, concentrated over time, sludge-like bile, which affects the filling and emptying of the gallbladder. So we'll kind of go bile becomes concentrated and such like. Okay. So what are some causes for this? This one's probably the least, the one we go over the least. Sedentary, kind of goes with it, kind of like diabetes, probably obesity. I put like a few extra, just like dehydration and stuff. Typically, it's caused by like poor flow and biliary status. Fasting can be one, yeah. Basically, um, someone, I think, let me double check on before I say it. Yeah, prolonged fasting for sure. Dehydration can be one, trauma can be one, eating low-fat meals. Yeah, that was basically what I wanted to check as being one, because the idea would be your your gallbladder isn't being used as much, so there's not as much need for the bile. So that's why your fasting can be one, because you're not really using the bile, so the bile concentrates and becomes sludgy. trauma, illness. Yeah, it's just kind of that. I don't think it's as focused. Your big focus is really going to be on acute versus chronic. So what's acute cholecystitis associated with? Your main association. Yeah, your gallstones. And what are some signs and symptoms for acute you guys can think about? Let's say nausea, vomiting, abdominal pain, specifically in the right upper quadrant. Yeah, yeah, that's the Murphy sign. Exactly. What else you gonna say? Murphy sign, anorexia, like lack of appetite. What else you guys say? Someone said jaundice. You can have jaundice from liver, liver involvement, liver and pancreas involvement could have pain, jaundice, increased liver labs and stuff. So, anorexia, food intolerance, nausea, vomiting, definitely a lot of pain, rebound tenderness. There's a pain that radiates to the shoulder. Let me see on that. Well, I'm getting tired, guys. I'm not gonna lie. Yeah, I can radiate to one of the shoulders. I think that's a decent amount of them. Okay, what about chronic cholecystitis? What's it mostly associated with? And obviously this is gonna be something that happens over long periods of time. Yeah, this one's like acute because it's happening suddenly. So why is it happening suddenly that you have inflammations? Because the gallstones. This one's happening over long periods of time. So what's happening here? Sludge, mucus buildup, chronic inflammation. That can happen. I think it's just like associated with inefficient bile emptying. So over time, you're just not able to empty it out as well. Some manifestations. What do you guys think? It's very similar, actually, very similar to the in terms of signs and symptoms. They can have a lot of similar things that acute does, but acute's gonna be more severe. But you'll still have that right upper quadrant pain, food intolerance. What are some chronic cholecystitis signs that are a bit more chronic, like a bit more sign that it's a chronic one rather than just the acute?
The different color of the stool.
Yeah, what's that? The clay colored stools. Perfect. Clay colored stools. You're also more likely to have the liver and pancreas involvement. It's a bit more likely to happen here over time. In which case you can have jaundice. Again, the increased liver function tests. Yeah, that's pretty much the steatorrhea here. Basically like fatty, no color. LFTs, bilirubin, which kind of goes with the jaundice. Dark urine, which is basically bilirubin in the urine, makes it dark. Let me see what else can be in there. Um, you have itching
Thank
to,
you.
what was that? Yeah, some random ones, elevated temperature, tachycardia. That's a lot of the same stuff. I think this is probably your main thing here. The clay colored stools, that's the main separating factor, and you're gonna have definitely more liver and pancreas involvement. Um, by like a significant amount, I think. Let me double check on that. Yeah, I think it could be both, but yeah, more common for this one. Okay. I think this is the section that we can get through a little bit faster, hopefully. So cholelithiasis, this is the actual having the gallstones. Contributing factors, I'm just gonna write some of them down. There's one that I want you guys to go over. So it's impaired gallbladder mobility and emptying. I have one here to remember like the 4 F's: female, 40, fat, and fertile. Because some of the contributing factors include pregnant women, middle-aged women, obese, sedentary, diabetes, HRT, rapid weight loss, lack of nutrition. I kind of just simplified it to 4 F's so it makes it easier to remember. So that could be something that helps you. I think that's important. So assessments, what are some assessments? We did talk about your PQRST. It should be right upper quadrant pain. We talked about Murphy's sign. And here is a picture for Murphy's sign. So specifically, you put pressure there. You tell them to exhale, put pressure there, and then tell them to breathe. So specifically, your Murphy sign is when the patient stops breathing in because they're in pain from the gallbladder being palpated as you're breathing in. So that's the positive Murphy sign. There's another one called Bloomberg sign, which is basically just having rebound tenderness, aka pain that is felt after pressure, like once you remove. So once you here they get pain and then you let go and it hurts still. GI symptoms due to fatty foods, fatty goods, fatty foods. Flatulence, that's like gassy, bloating, indigestion, burping, nausea, vomiting, abdominal pain. Obstructive jaundice. We talked about that. like the jaundice, like the liver involvement, all that stuff there. Some labs. What labs would be different? What would we look at for general gallstones? So probably the ones in the cystic duct more than anything. It's just silent. Sorry, I don't know if maybe I wasn't loud. Just like what labs could we see with the cholelithiasis, so the gallstones? Okay. Right side increase LFTs. And if you want to be specific, yeah, the LFTs, if you have liver involvement, your ALT, AST can be increased. Your ALP is like a blockage one. So that would be one that you might see be increased when there's blockage. Let's see if I the bilirubin, ALP. ALP is like the blockage one. Yeah, serum amylase and lipase. This is let's see, so this is signifying liver involvement. This is signifying pancreas involvement. And it's be decreased. Oh, sorry. Yeah, I think it's decreased. That's what I thought. For some reason I have decreased. I'm gonna double check on that. Yeah, let me double check. Yeah, increase. I don't know why I have increase rather. I don't know why I have decreased on there. That's incorrect, man. Yeah, pancreatitis. What happened? What happened? Oh, oh. I was like, what? Why'd you say Jesus? What happened? Oh, fourth. Damn. That is quite a bit. Yeah, that's crazy. PT, increased white blood cell count. PT, that has to do with your LFT, your liver makes coagulation factors and stuff. Oh, I'm getting tired. I'm sorry. Uh, This is close to my bedtime. Um, what are some diagnostics? It's like a few that's like two main ones really. 2/3. Yeah, your ultrasound of your gallbladder and your ERCP/MRCP. Ultrasound of your gallbladder. It's your best first diagnostic for cholecystitis. You just gotta be MPO. And I guess we'll do like fasting before test to assess gallbladder, file. Obviously gonna be MPO. You're just gonna see if there's inflammation going on. Your ERCP, this is your something that lets you both see and remove stones. So you have the ability to see and remove stones. So you might do it just to see, and if there's nothing there, you're done. Or if there is something there, you decide, and by you, I mean not you, actually, the doctor, but they can remove the stones as well. Oral contrast is used, so assess for allergies. So assess for allergies. The gold standard, yeah, this is like your gold standard for your gold standard pretty much. Yeah, your MRCP is done with like an MRI instead of it being done like endoscopic. Yeah, I guess I'll just do separate them. Obviously, contra indicated in patients with pacemakers because MRI, no metal or contrast. MPO, informed consent. Okay. Any confusion or do you guys want more detail on this? I'm just trying to get it done at this point. I'm sorry. Um, yeah, so then common bile duct obstruction caused by calculus. Not the math one, but the one in your gallbladder. So aka gallstones. And it can result in, we talked about it, pancreatitis. Because again, if you saw the picture, actually I have an extra picture about it. Boom. You can see here, so here is some stones. The stones are passing through here. They're actually not getting stuck in the they're not getting stuck in the cystic duct here. So they're not just doing acute cholecystitis. You'll see them actually travel all the way here and actually get stuck here in the pancreatic duct, in the common bile duct. Get stuck in the common bile duct, which you can see is very closely related to or very closely connected to the pancreatic duct. So it starts to cause blockage in the pancreatic duct as well. So that's why that happens. So then some manifestations of this, and you guys will go over pancreatitis on its own in 232. But just it's called biliary colic, which is severe pain related to gallstones. Some things that are associated with it are tachycardia, paleness, diaphoresis, sweating, and jaundice. So you can have jaundice, what's kind of already there. The typical clay-colored stools this is just for a CBD obstruction. So not pancreatitis, but just CBD obstruction. Dark foamy urine, due to bilirubin in urine, clay-colored stools. Talked about the bile's not reaching the intestines. Yes, diarrhea as well. Diarrhea, which means fatty stools. Float. Now, general management for cholecystitis. All right, what's some non-surgical things for someone with cholecystitis? They're having right upper quadrant abdominal pain, causing they have pain, inflammation whenever their gallbladder is used. Their gallbladder is used whenever they eat fatty food. So what's a good thing to not do? Or what's a good thing to do? It's okay. Opioids can be a thing if you want it with the pain. The low fat diet, something we want to do over time. What's like the first thing you would do if they're coming in? MPO. In general, just want to have them MPO because you want them to rest the gallbladder. So rest the gallbladder, which means you're going to go from an MPO at the start to rest, progressing towards a low fat diet eventually. Okay, once you make good progress, you can start going to a low fat diet. You're going to start MPO because you want to rest the bowels, rest the gallbladder. Can have an NG tube to suction, to decompress decompress the bowels. My wing stop. We had Anne, was it? Was it Anne? She mentioned opioids. Yeah. So pain management. We can have opioids. We can have NSAIDs. IB therapy. Yeah. So if they have nausea, vomiting, IB fluids. If nausea, vomiting, because we want to replenish their fluids. Okay. So if they have nausea, vomiting, they might also get antiemetics, such as Sofran, aka ondansetron fluids, yeah, for nausea, vomiting. We already talked about the ERCP. That's kind of cholecystectomy, diagnostics. We already talked about ERCP. We did a bit more detail there. Did we do more detail? Or did we have more detail? Okay. I guess I'll add an extra thing, which is you can use the ERCP to place stents. Um, okay. So we said ERCP. What else? That's gonna be your main one, really, for the very general. I'm gonna add one for complications. What's a major complication? Let's say you have you have a stone and it's stuck in a duct. So you have a little tiny little spot being completely blocked off, obstructed. So now I want you guys to think back when we talked about, okay, perfect. Yeah, perfect. You're gonna have perforation. So when you have something that gets blocked off, built up, it gets perforated. What happens when it gets perforated? Anne said you get shock, you get sepsis, peritonitis. All right, excellent. I'm glad I drilled that into you guys. It's perfect. Perforation, you can lead to shock, you can lead to sepsis, peritonitis, which we remember is very, very deadly because it's a big area that's getting infected and stuff. So yeah, that's a big one. Peritonitis, shock, perforation. Hard, yeah, I remember peritonitis is that hard board-like abdomen. Yeah, perfect. All right, so what's the name of the surgery? So it's a cholecystectomy, but what is your the gold standard is the laparoscopic cholecystectomy. So kind of like your ERCP, your lap chole is something that can be done just to check. You can use it, you can do it to check and be like, do we need to do like is it good to go in now and operate, or can we also um do something about it. So we can go in and you can decide, do we need to actually get rid of the whole gallbladder or not? There's also an open traditional, so I kind of have that here, but it's not as common because this has so much less complication. This is your gold standard, your lap chole. So pre-op for lap chole, they're going to be MPO, and that's your priority. That's a big priority. Obtain signed consent. You're going to want consent, but if you can only choose one thing to do, remember this person is likely having issues with their gallbladder and abdominal pain, so MPO is going to be your priority. If you can only choose one, you're going to do this first because it also helps them with their symptoms. Okay? So it's important because you need to do it for surgery, but it's important because it also helps decompress, like, helps with the resting the bowels thing we talked about. Here helps to rest gallbladder, and also important for pre-op because again, we don't want them to aspirate and whatnot. So MPO is your priority, obtain signed consent. A lot of your typical pre-op procedures. At this point, pre-op comes with a lot of pre-op and post-op have a lot of very similar stuff. So you have your skip thing, you have your antibiotics, your um yeah, vital sign assessment, etc., etc. Cessation, yeah, no more anticoags, etc. Semi-foulers, all that good stuff, right? So over time, this just becomes second nature on the pre-op stuff. What about post-op? So now they have gotten the lap cholecystectomy. What are some things that we need to do, or some things that should be done? Yeah, I'll include this here. Vital signs always important. I guess something that I'll include here is the part of the procedure involves inflating the abdomen with carbon dioxide. Yeah, so your early ambulation is important, not just because it's obviously your post-op, but also because the also helps to remove remaining CO2 in abdomen. So they do the CO2 to help them um, visualize. I believe help with visualization um, of what's going on when they're in there. Um, so then because your abdomen is pumped up with CO2, that can cause pain and discomfort. So early ambulation helps to remove it. Same with semi-foulers. Um, so he said advanced diet is tolerated. Yes. So that's, yeah, your classic advanced diet is tolerated. Your classic IS, turn, cough, deep breathe, splinting, whatever you need. Yeah, assess for infection. Yeah, pretty much infection, bleeding, all of your very typical stuff. So, something else to note is that you can have shoulder pain because of the CO2. So it would probably be like right somewhere. So may have pain that manifest in the shoulder from CO2. Let's see. Jennifer asks, Dermabond and Steri-strips are the same? I have no idea, if I'm being honest. Let's find out. What is a Dermabond? They're skin adhesives. Yeah, they don't look like they're the same thing. Your professor asked you? Okay. Yeah, they don't look like the same thing. Yeah, Thermobond's like a glue, looks like skin super glue. Yeah, it's literally called, yeah, it's literally a skin adhesive. Oh man. Wait, that's what he did? Heard that like cut his finger like entirely and then just like casually like glued it back together. She actually made you hold the finger, or he made you hold the finger too. He's like, here you go. Oh, he duct taped it. Crazy. Wow, you still have it. That's perfect. Amazing. That's incredible. Yeah, some patient education. Just allow the steri strips to come off on their own. Remember the low fat diet, because again, your gallbladder is gone. So, yeah, low fat diet, add fats slowly back into the diet. When to ask for help. Yeah, the post cholecystectomy syndrome. That's like a thing. So, so it's repeat abdominal pain, nausea, vomiting, diarrhea, week or months after. Pretty rare, but more common with um, traditional than anything. So post-cholecystectomy syndrome is abdominal pain with nausea, vomiting, diarrhea, weeks or a month after. And of course, they should know signs and symptoms of infection. So we're almost done. Okay. Your pre-op is really going to be standard pre-op, so I'll just delete that. It's your standard pre-op. The same pre-op in that as used for everything. Your post-op though, you're gonna have a JP drain. Um, just know you want to obviously document amount and color. The JP drain, you want to keep it. You want to empty it out. You want to squeeze it and then close it so you can keep that negative pressure. So 50 to 100 ml in the first 24 hours is okay. Um, above above 100 ml, report to the MD for this one. So let's see. So that's the JP drain. So there's actually another one called a T-tube. So let's go take a look at what that looks like. I guess that works. So it is there to essentially be a drain for the drainage for vial. Yeah, it does look like a T. Oh, I guess that's interesting. We I don't like that picture actually. Okay. So it is allows for drainage of bile while the common bile duct is recovering. So we can see here, you still have that common bile duct. So this helps as an extra way to drain stuff so that this can take a bit of a rest since we, did an invasive surgery on it. This one's probably good. I like this picture. Okay, so normal amount of discharge. 500 to 1000 ml post-op day 1. After post-op day 1, then it should be 300 to 500 ml. And if it's more than 500 ml, after post-op day 1, if more than 500 ml, you gotta call the doctor. So just know the things to watch out for. When it comes to the T2, like the amount of discharge that's normal. When do you call the doctor? And just keep in mind that on post-op day 1, you can have more. And that's going to be a common thing. Post-op day 1, the parameters will be different than after. The color of it, let me see. I think that sounds about right, like a yellow greenish color, but let me double check on that. Yeah, green yellow. Yeah, it's like a green yellow color. On the green yellow discharge, aka bile. Just keep below level of gallbladder to have that, so you can have that gravity helping you out. Patient can go home with it. At least for weeks. And then other than that, you'll have like typical post-op. Typical post-op, turn cough, deep breathe, IS, splint, pain meds, early ambulation. All the classics on that. Oh, actually, I actually have another picture. I actually like this one. I like this one better. You still see the little T. You like the little thing where it's like, oh, it's removed. But that's everything. I didn't, there's actually a lot. I didn't give you guys as much time to do, interact. It wasn't as interactive as I would have liked, but I don't, I think we would have been here for too long if if it was more interactive, unfortunately. So I'm sorry about that. But I will also give you guys this little table. I don't know if I want it at the beginning or at the end. I think I'll put it in the beginning. I have this little table. Should be helpful. Boom. So here it's like this table, different types of cholecystitis, some factors, diagnostics, kind of all in just one little table. And this one here on lap chole versus open cholecystectomy, just a nice little table for super shorthand on the gallbladder. Man, this thing is long. I feel so bad for you guys. Oh man. It's okay, it's almost over. It's almost over. Yeah, this is a lot of stuff. Kind of going back through everything. I'm gonna give you guys the PDF in a little bit. I'm just gonna go back through everything. Negative feedback is important to know. Understanding that the labs, understanding the hyperthyroidism, everything speeds up. A temperature is a really big deal. You need to be able to differentiate thyroid storm from just hyperthyroidism. The meds, of course, you need to know your meds. Just keep this in mind. Man. All right. Your surgery, when are you indicated for it? Definitely know your thyroid storm. Very big deal. Understand the use of propranolol, how it's for thyroid storm. It's used for thyroid storm and not so much just hyperthyroidism. Someone with hyperthyroidism can be among us. They can just be existing. You know, they might be fine on just their Tapazole and PTU, so that's why it's not in here on pharmacological for hyperthyroidism. But for this, because you end up having this sympathetic response, you need to treat the heart rate and blood pressure. Definitely know about decreasing your stimuli. Understand the complications with thyroidectomy. So definitely understand your hypocalcemia. The stridor is a really big deal. Need to call the rapid. You can have thyroid storm still. Hypothyroidism, make sure you know everything slows down. The medication is going to be different, of course. Increase your rest and stuff. Your in general airway is pretty important with your hypothyroidism, with your myxedema coma, with your post-surgery. The airway becomes key always. Then we move on to gallbladder. You have the different types of it. Just understand the differences between acute and chronic. So your chronic is very much more related with the clay-colored stools and steatorrhea, so this is the fatty stools, due to lack of bile. Your chronic cholecystitis is also more involved with liver and pancreas involvement. Trying to figure out why this was wrong on the notes. I'm just gonna double check something. Yeah, it says elevate, normal or elevated. So yeah, that seems to be the case. Not sure why they were wrong on my notes. Dark urine, and it seems like you guys agree with this, right? You guys agree with it being increased on the manifestations? Just making sure. I really don't want to lead you guys the wrong way. It makes sense to me. I'm not sure why it's written wrong on my on my note. Yeah, okay, perfect. So I'll fix it here, I guess. Okay. Cholelithiasis, we said we can kind of cluster this into the 4Fs. Keep in mind the Murphy sign is important with your cholelithiasis. You have cholecystitis because acute cholecystitis is caused by your gallstones. So the Murphy sign specifically, it's when they stop breathing because they're in pain trying to catch their breath. Once you put pressure, they breathe in trying to breathe and they stop breathing like they'll stop their inspiration because they're in pain. There's rebound tenderness. These laps here, the LFTs, your pancreas, you just know that there can be an involvement with the liver and pancreas because we showed the picture here that if this is being blocked off here, then obviously it's going to affect the liver. It's going to affect the pancreas because they're both kind of together. Your ERCP, ability to see and remove stones, just your manifestations. Resting your gallbladder is a priority, so MPO. Complications include perforation, and it seems you guys really got that down. Your gold standard surgery is our lap chole. Again, your MPO is your priority. Helps to rest the gallbladder, and you also need it for pre-op, so it's going to be the main thing you do. You can have pain because the procedure involves putting air, CO2 into it, so early ambulation, semi-Fowler's helps with that. Some education. Patient's gonna be advanced in their diet, eventually go into a low fat diet from MPO, starting on MPO. With your traditional open, just know the what's okay on the drainage. Same thing with this, and then don't get caught with this, because at post-op day 1, you're going to have different numbers simply because you just started, you just finish manipulating it, so it's going to be higher. But then afterwards, know when to call the doctor for that, and you guys know your typical post-ops, and that's that. Um, at least now with it being so long, you guys still have until Friday, so that's good. Normally, the reason I was doing mine on Friday was because on Tuesday I had clinical. So today was actually my last clinical day. Um, so we're done with that finally. So I was able to, after after we finished clinical, come here and do this. Yeah. Same with Kaylin. Kaylin finished yesterday actually, because she went on Monday. Yep, we're all getting ready for preceptorship. It's gonna be fun. Well, I don't know if it's gonna be fun, but it's gonna be different. So I sent you guys the PDF, so once you guys have it, I'll stop recording now.